Hello, everybody. Hope you had a great lunch and are ready for some more fantastic talks and stimulating discussion during the second half of today's conference. My name is Sinnott. I'm a GP and a clinical research associate here at this institute, and I'm very excited to be chairing what promises to be a very engaging session on what's the problem with access to general practice today. So, access to general practice, as you know, it's a pervasive problem for healthcare policymakers and practitioners worldwide. It's particularly a problem in NHS general practice, where the measures that we use to study general practice or access are often based on narrow measures, such as the timeliness or the supply of appointments. So these are certainly important measures, but they are quite narrow and don't tell us the full story of people's experience of access. And we now have a situation in NHS general practice where the apparent supply of appointments is rising, but patient satisfaction to general practice seems to be declining. So in this session today, we're going to ask, have these measures misled us somewhat? We're going to look at past approaches to improving access to general practice. We're going to take a deep dive into some of the more used approaches and see what effect they've had on the ground, and look at alternative ways to studying or evaluating access to general practice that might illuminate a path forward. So the session will start with three short talks. Kicking these talks off is Jake Beech, a policy fellow from the Health Foundation. And in 8 minutes, Jake will take us through 20 years of healthcare policy and access to general practice. Jake will be followed by Helen Atherton, a professor of primary care research at the University of Southampton. And Helen will take us on that deeper dive into some of the previous approaches to improving access and the effects that they have had. Then we have our very own Akbar Ansari, a research associate at the Healthcare Improvement Studies Institute. Akbar will cover some of the problems that can arise from using narrow measures of access to general practice, and propose that using a more patient-focused, a broader framework that draws on the candidacy framework might be useful in developing solutions for the future. So after these three talks, we will be joined on the panel by Kath Checkland, a professor of healthcare policy and primary care from the University of Manchester, and Azim Majid, a professor of primary care and public health from Imperial College London. We have about 25 minutes for our panel discussion, and as with the earlier talks today, we're really keen to hear your thoughts, your comments, your reflections on what's been discussed. So please do put these observations into the Q&A, and we'll try and pick them up and put them to our panel. So without much further ado, I'll hand the floor over to Jake Beech, who will be followed by Helen and Akbar, and we'll see you then for the panel discussion. Thank you very much.
Hi there, I'm Jake Beech and I'm a Policy Fellow at the Health Foundation, and I'm going to talk you through for this presentation some of the trends in GP access policy over the last 25 years. So why is it important to understand the past approaches to improving access? Well, it's important to have that context to know what's been tried before, what's worked, what hasn't, and how different governments have thought about access and conceptualised GP access over time. What I'm going to do in this presentation is talk you through some of the key flagship policies on GP access from different governments over the last 25 years to provide some context and hopefully some learning as well. I'm not aiming to be comprehensive, but it will hopefully give you a sense of the flavour of different governments, what has been tried and what were the priorities across time. This work forms part of the IMPRESS project done in collaboration between this institute and the Health Foundation, and my colleague Akbar will be talking you through more of IMPRESS's work a little later on. This presentation is based on a review of around 46 key national policy documents from the year 2000 to the year 2023, so that's the period we'll be covering. So to begin with, I'll start with the Blair government under Labour. So this government very much had a flagship policy, the 24 48-hour access target for general practice. So this is the idea that you would see a primary care professional within 24 hours or a GP specifically within 48 hours. You had that right. That was the flagship government from the Labour government at this time. Sorry, the flagship policy from the Labour government at this time. But it wasn't the only policy. Other policies introduced under the Blair government included one-stop primary care centres, a programme of premises modernisation, and and cultivating a market for new providers, new general practice providers to enter the primary care medical market through the introduction of new contract types, PMS, APMS, PCTMS, and new market opportunities, the out-of-hours provision that was taken out of the 2004 baseline GP contract. And throughout this period, you saw promotion of choice, competition, and convenience as organising principles, and a focus on commuters, which isn't something we tend to hear about today. The idea of introducing the ability for patients to register at two general practices, one near work and one near home, to enable that choice and convenience. Moving on to the Brown era of the Labour government, we saw the continuation of a lot of similar themes, but we also saw the introduction of a pledge for 100 new GP practices in the areas of poorest provision and 150 GP-run health centres open 7 days a week as key flagship policies under Brown. You also saw the introduction of a number of measures to address access problems arising from previous policies as well. So issues arose with booking appointments in advance of 24 and 48-hour targets. So there are a number of policies intending to address that and open up more in advance booking for patients. And we also saw a number of measures aiming to introduce incentives for more out-of-hours provision as part of the GP contract, to help with some issues that were introduced in the 2004 contract reforms as well. So efforts to eradicate problems with access introduced by other policies intending to improve it in other ways. So moving on to the Conservative and Lib Dem coalition. In this period, you saw a continuing focus on choice, again, perhaps even more so, with introduction of the right to register with any GP, the introduction of Health Watch as an advocate for patients and as a way of providing choice and for advocating for patients locally to register with practices that they want to, and more metrics to base patient choice on. We saw the introduction of two key programmes, the PM's Challenge Fund and Vanguards, as a way of piloting general practice models and a way of piloting ways of improving access with a view to scaling them up if they were successful. And during this period, we also saw, building on the Labour government's approach, the introduction of clinical commissioning groups and local commissioners having strong control and co-commissioning powers over general practice locally to help provide services that meet local access needs. So again, a continuing focus on local commissioners as a lever for improving access. Moving on to the Conservative government under Cameron specifically, we saw an increasing focus on workforce. We saw a pledge to increase the number of doctors in general practice by 5,000. We saw increasing focus on retention and skill mix policies. For example, the introduction of pilots for new physician associates. We saw an increasing focus on 7-day services and a scaling of PM Challenge Fund innovations. And perhaps overall, a pivot from competition to collaboration while still preserving choice as an organising principle for some of these approaches to improving access. Moving on to May, we saw the introduction of primary care networks under her tenure. So these are groups of general practices, usually with a collective population of around 30 to 50,000 patients, coming together to provide new services to patients in return for additional investment, and a huge amount of growth in new roles, the additional roles working within primary care networks. So a flagship policy of this era was the additional roles reimbursement scheme, central reimbursement for primary care networks, employing up to 20,000 new staff in roles like pharmacists, physiotherapists, paramedics, social prescribing link workers, again with the aim of improving access. During this period, we also saw the growth of NHS 111, an interest in self-management support and GP booking provided through 111, and a focus on the initial steps towards digital-first primary care and a right for all patients to have access to that in the near future. Under the Johnson government, that latter policy was really turbocharged by the COVID-19 pandemic. So there was a dramatic change in online access to general practice, remote consultations as a result of the pandemic, and policies introduced during the Johnson government attempted to sort of make good on that and implement these in an effective way. The Conservative government at this time also pledged to, again, focus on the workforce, increasing the number of GPs by 6,000 and the number of appointments by 50 million, increasing the additional roles reimbursement scheme cap from 20,000 to 26,000. There was a strong interest in cutting GP bureaucracy and the start of incentives and OD support coming in to help practices improve access locally, a focus on that as well. So finally, moving on to the Conservative government under Truss and Sunak, we again see that focus continuing on the local support for general practice to make changes to their processes and tools to improve access through the General Practice Improvement Programme, local OD support. There was the introduction of a 2-week access expectation, so not a target, but the expectation that patients who needed non-urgent GP care would have an appointment within 2 weeks. And we saw the emergence of this idea of modern general practice access, of ending the ATM scramble and improving the front door experience for patients. And then finally, that continuing focus on workforce as set out in the NHS Workforce Plan. So what can we learn from this? Well, there's a number of lessons. First one is, of course, the re-emergence of policies over time. So we see continued interest across governments in self-referral and greater use of community pharmacy to help take off some of the pressure on general practice. We see a continuing focus across both Labour and Conservative governments under different leaders in choice, competition, better information for payments. These are very consistent across time as a vehicle for improving access. We've seen a range of policies that have been tried over time, and we find there's often never easy solutions to access questions. They're hard to implement. There's trade-offs and unintended consequences. Again, the archetypal example of this is, of course, the 48-hour target and the unintended consequences for being able to book in advance that marked that policy. But that is by no means the only policy with trade-offs and unintended consequences. And then finally, we see policies in recent years have been heavily shaped by the lack of GPs and a need to improve the number of GPs working in general practice to help improve access, or the introduction of measures like skill exchange to address some of the challenges arising from a lack of GPs. So thank you for listening to this talk. I hope it provided important and useful context for the conversation we'll be having slightly later. Please do feel free to get in touch at the email there. Thank you very much.
So today I'll be talking about the GP sus study, getting an appointment to see a GP, case study learning about sustainable access systems. It won't be news to anyone that access is an incredibly topical issue, and it's a big concern for patients, general practice, policymakers. And general practice has attempted to manage supply and demand using various different approaches, phone and online triage, varying appointment availability and number of problems, diverting patients to other clinicians, such as pharmacists, or non-clinicians, such as social prescribers, and offering other consultation modes, so asynchronous text messages, video consultation, and other approaches. The GP sus study sought to describe and compare the longer-term impacts of some of these different approaches to patient access to general practice. And we wanted to understand whether the various approaches worked as anticipated, were adapted or abandoned, or whether they were able to sustain any improvement over time. And we did this via a scoping review, focused ethnographic case studies, and collaborative workshops. And today I'll be talking about the scoping review and the focused ethnographic case studies. The way that we identified practices that had taken different approaches to patient access was via our scoping review. And in this review, we consolidated the different international evidence base related to different types of GP access systems. So this was where research studies had been conducted to look at an approach to access in general practice. And what was interesting about this review is that we found 49 studies, and the majority of them were set in the UK. So we're very good in the UK at doing this kind of research. And when we looked at the systems that were examined, advanced access, telephone triage, and online consultations featured heavily. So advanced access is doing today's work today. Telephone triage included telephone first systems and sort of comparing GP and nurse-led triage. And there were two key strategies that were adopted by the systems that we identified. They were either changing appointment capacity, modifying patient pathways, or doing both of those things. The review helped us to identify the practices for our case studies. So we did focused ethnographic case studies in 8 general practices in England and 1 in Denmark. And today I'll be talking about our English practices, but we are doing a separate cross-cultural comparison between Denmark and England. The practices were located across England, as demonstrated by the stars on the diagram that are not necessarily all that accurate in location, but give you an idea. And the practices had at least 3 years' experience of the implementation of an innovative access system identified via our review. And we did observations, informal conversations, interviews with staff and patients, and document collection, and applied thematic analysis to all of our data. Now, this slide tells you something about the practices that were included in the research. They varied by characteristics such as list size and deprivation score, with one being the most deprived areas, and also in terms of locality. And when we looked at the studies they were previously involved in, there was advanced access, different telephone first approaches, and alternatives to the face-to-face consultation. We also sampled 2 practices that had not been part of a previous research study. One of these was sampled for deprivation, and the other was sampled because not only were they in a deprived area, but they were using a lot of allied health professionals and other healthcare professionals to deliver care. And this is very topical at the moment with the additional roles reimbursement scheme in general practice. When we looked at what the practices were doing, the majority of them were using telephone for their communication with patients about appointments, but there were various other elements. And when asked about why they were trying to kind of control access and put things in place to support this, there were varied answers. Did not attend, so missed appointments were a key factor for some practices, but for others it was purely about ensuring that patients could get through and get an appointment if they needed to. So I'm going to share with you some headline findings from these case studies. And our practices, they wanted to change access, so they introduced a system for doing that. Was this sustainable? No, that probably isn't a big surprise to anybody. And are these practices still using them as intended? No. Why was this and what happened? Well, the local context was really important, and the challenges that brought. And these were often more complex than the access system allowed for. Changes had to be made, and these were often at the micro level. It might even be at the level of this practice within this town, rather than necessarily to do with perhaps policies at the national level. Changes to the health service, increased demand, pressure on staff creates tension. It's very difficult to engage with change when things are pressured. Irreconcilable perspectives. So patients in the practice understanding the situation quite differently, but neither side being necessarily aware that that is happening. Management of demand seen as the only solution, resulting in layers of access. So as the demand increases, further layers of access would come in, for example, adding in online consultations, adding in the amount of problems you can bring to the consultation. And evolutions and workarounds were used by the practices to solve the immediate problems in front of them, but are not necessarily a sustainable way to manage access. I'm going to share with you now some quotes from our work, which hopefully illustrates some of these points a little further. Misaligned expectations. This was a GP talking about how things have changed in terms of perspectives about GPs and general practice, but also commenting on the fact that people no longer self-care, talking about someone wanting to see a GP after one day of a sore throat. But in another practice, a patient talked about coming to the UK, bringing her daughter to the GP and finding that they weren't helpful because they asked them to observe and wait for more information. So this watchful waiting was not well received, and they said that it was a fall behind their expectations. So these misaligned expectations were something that we saw quite commonly between the two groups. And irreconcilable perspectives. So this was a GP and a patient in the same practice, and the GP said it was very rare that a patient couldn't get through and be seen and there was a problem. But the patient said that the access system, the appointment system, doesn't work. because they'd rung first thing in the morning, and then they were on the phone in number 26 in the queue, and eventually they got through and there were no appointments left. So this was very interesting to observe these kind of irreconcilable perspectives about what was actually happening. So to conclude, practices have moved away from fixed models which are not sustainable, and the flexibility to adapt to their population, to what's happening around them, is important. They're constantly having to tinker with systems to make them work, and that is work in itself. There are clear mismatches in understanding and perception between practice and patient, and tackling this and targeting perspectives and expectations is likely to be a crucial element of tackling the access issue. Thank you.
Good afternoon, everyone. My name is Akbar Ansari. I'm a researcher at this institute and part of the team that has been working with the Health Foundation over the last 2 years on a programme of work looking at access to general practice, which I'm going to introduce to you today. As we've heard from earlier speakers, access to general practice is something which we know is a priority for patients, practitioners, and policymakers alike. Our work in this programme aims to provide a more comprehensive understanding of access. To do so, it is looking at access in a very broad sense, using a theoretical framework called the CANC framework. The goal of the programme is to develop a new framework specifically tailored for general practice, CANC-GP, which will hopefully allow for a deeper understanding of access challenges, as well as help identify promising solutions. So, what is the CANC framework? Well, it was originally developed in 2006 by Mary Dixon Woods and colleagues in an effort to better understand access to healthcare by vulnerable groups. It sought to provide a more holistic approach to the study of access by paying attention to how people identify themselves and move through healthcare systems as candidates for care. At the heart of the framework is the idea that access is a dynamic process subject to multiple diverse influences. The framework itself consists of 7 features that are key to how people engage and interact with healthcare services. To begin with, there is identification, identifying the need for medical attention. Significantly, people have different thresholds for deciding to seek care, which can be influenced by a wide range of different factors. Next, there is navigation, choosing between different healthcare services. Rapid shifts in the organisation and delivery of healthcare can potentially leave patients unsure of what to expect from services and where exactly they should go. Third feature is permeability, gaining entry to a particular healthcare service. How appointments are requested and conducted, and the criteria patients must meet to get offered a particular type of appointment have an impact on this. Fourth are appearances, articulating the need for medical attention. Some people may be more able than others to use their voice. They may be more confident and more persistent, ensuring that their needs are better heard. After this, there are adjudications, which are the decisions made by healthcare professionals. Adjudications can draw on different kinds of expertise, as well as broader contextual knowledge, and are important to people's perception of access. Next, we have offers and resistance, which are also important to people's perception of access. Patients can accept, refuse, or be resistant to offers of care. They may feel that the offers being made to them are not appropriate or adequate for their needs. Offers don't necessarily just relate to interventions or referrals. They may also relate to advice and reassurance. Finally, we have operating conditions, the wider contextual influences and resources that may affect a patient's journey. In summary then, according to the CANC framework, access is a function of how people understand their symptoms, recognise and choose healthcare services, have the means to find their way to and into them, and can articulate their needs in a way that can be adjudicated and acted upon, all of which takes place in healthcare settings that are part of a wider system. Relative strengths of the framework are that it potentially offers the opportunity for a more granular analysis of the entire patient journey, and that it allows for further recognition of the contextual factors that may shape access. So, Having explained the CANSI framework in a little more detail, let's now look at the work we have been doing at this with the Health Foundation. The programme involves 3 work packages. First, we have undertaken a review of the literature through the lens of the CANSI framework. This has had 2 main elements: a systematic review of the use of CANSI in the study of general practice, which identified over 50 papers, and a scoping review that explored the applicability of the CANSI framework to the broader literature on access to general practice, which looks at over 200 papers. Taken together, these reviews have shown that the CANSI framework has been and is a valuable tool with which to study access to general practice, but would also benefit from being customised. Second, we compiled a list of interventions to improve access to general practice, identifying 103 different types of interventions between 1984 and 2023. We then organised the interventions into 6 categories and assessed which features of the CANSI framework each intervention addressed. We found that permeability of services, gaining entry to a particular healthcare service, was the most frequent feature addressed by the interventions. Far fewer addressed the features of identification or navigation, or how decisions are made and communicated during healthcare interactions. Third, we have undertaken a qualitative interview study with patients, carers, and general practice staff. We conducted 70 semi-structured interviews. 41 were with a diverse group of patients and carers, 29 with staff. We asked patients and carers about their most recent experience of accessing their general practice, and we asked staff, both clinical and administrative, about 3 cases from their most recent day in practice. Analysis is currently ongoing, but initial findings include there being challenges in striking the right balance between ensuring general practice can be responsive to immediate patient needs, while simultaneously providing preventative and longitudinal care, and there being gaps between what patients hope or expect an interaction with their general practice will look like and how it plays out in reality. From these 3 work packages, then, we're going to develop the new framework, CANSI GP, with the aim of helping to inform where improvements to access are most needed, to understand why previous efforts to improve access have failed, and to identify promising solutions. Thank you very much.
Great. Thank you to all 3 of our speakers, Jake, Akbar, and Helen, for those fantastic engaging presentations. So I'd like to welcome the 3 of you onto the panel, where we are also joined by Kath Checkland from the University of Manchester and Azim Majid from Imperial College London. So lots of questions coming in now and lots of discussion in the chat. But Kath, I'd like to go to you first, maybe. You'd mentioned that you'd been a GP and an academic through many of the different policies that Jake described. Can you give us your reflections on some of those and what it was like being on the point of delivering them to your patients?
Yes, thank you very much. And thanks very much for inviting me to be here today. This is a topic very close to my heart and it's lovely to be here. So yes, Jake's history encompasses almost the entirety of, well, in fact, it does encompass the entirety of my working life as a GP. So it's rather disconcerting to find myself being part of history. But I've lived through each and every one of those initiatives. I have to say that I think I survived. I would call myself as having survived advanced access, which I think probably was the most disastrous policy ever implemented in primary care, and there's quite a high bar for that, but it was absolutely dire for lots and lots of reasons, which there isn't really time to go into. I think one of the issues is that the people making these policies do them with the idea they have a sort of typical or typical person in their heads when they're inventing the policy, and that coincidentally that person is often very like them. So we've had a lot of policies which have been kind of focused upon commuters or working people who need rapid access, and I think that's because the policymakers, we all know we all access general practice, so we all know what we think access should be, and we do a policy which will make it better for us, and we forget about everybody else. And I think that's one strength of the candidacy framework. The most recent work that I've been doing on this has been with my colleague Jen Voorhees, who's been doing some work which is actually quite similar and is building, I think, a lot on on the notions of candidacy and the ideas that are in the candidacy framework, which I like a lot. But I think it misses slightly something. And Jen's work focuses on human fit and thinks about the fit between the patients, and I think that's very compatible with the candidacy framework. But what it does introduce, which doesn't come out quite so much from the candidacy framework as I would like, is that it introduces the sort of human capacities of the other side, because receptionists are humans. And I think that's one of the things that we forget, that when receptionists are working under pressure, they become stressed, and then they become less permeable. And so I think thinking of it as the human fit between the patients and the professionals and the staff is a really good way to think it through. So and I think we've been working with Helen and colleagues and thinking around these sorts of, and Jake, and thinking around these sorts of issues, because I think if we can get practices thinking with their patients how they might improve access for everybody, we might do an awful lot better than having these top down, here's something you all do. And advanced access was just dire.
Great. We might come back to your experiences of advanced access if we've time, Kath. But Azim, I might just get you to pick up on some of the points that Kath mentioned, which also reflect some of the questions that are coming in through the Q&A platform. So you'll have to excuse me as I look down, because I'm trying to look at the questions as they're coming in too. So for example, Carly Jones asked, what is the best way forward to improve access without increasing health inequalities further, as Kath suggested some previous policies might have done? While there are also questions from Jill Travers saying, again, how do we address disparities in access for people, for example, that don't have English as their first language? And a similar question from Abida Rafiq on racial inequalities. So it's a bit of a tough opener for you, Azim, but would you be able to speak to any of those issues and where previous policies might have led us down, and what we might think about moving forward?
Thank you very much, Carol, and thanks to Jake, Akbar and Helen for excellent presentations. So I think we have in recent years seen expansion in primary care departments, which is good, but the challenge has been that the demand has risen probably at an even higher level. So we still have this gap between capacity and demand in primary care. Also, I think with policy often is a few years behind the current scenario. So in recent years, we've seen an expansion of non-medical professionals like pharmacists and PAs because we had a lack of GPs. But actually, we now have more GPs than there are GP roles in the NHS. So there's an opportunity to rethink some of that demand management, and perhaps think about refocusing on expanding GP numbers rather than these other professional groups. I think around inequalities, I think that's very important. So again, in recent years, we've seen a lot of focus on digital access tools, so using online portals, NHS app, forms like eConsult, for example, or IQRX. And those will exclude people who aren't very IT literate, so older people often, or those with poor English language skills, or minority groups. So it's very important that people do maintain a range of access points to primary care. So home practice, we maintain, people can book appointments in person, by telephone, by email, or by one of these newer online portals. So very important, that the practice don't switch to digital only, for example, for accessing primary care, because that will exclude a lot of people, particularly those who say who are older or perhaps from minority groups.
Thank you very much, Azim, for that. Again, just picking up on some of those points, and Helen, I might go to you on this because you're kind of synonymous with eConsult research in the UK, I think, over the last kind of decade and a half at this point, Helen. And in terms of how some of these asynchronous approaches to offering access to patients have been implemented, could you speak to us a little bit about what that promised, what it delivered, and how some people have been left behind, and with a view to how we might move forward by continuing to use these asynchronous platforms in a way that is more equitable?
Sure. So it's really interesting because we had these platforms in general practice before the pandemic, but they weren't very well used, and they were very much optional. And then obviously lots of changes through the last few years, real push towards digital first policy, which Jake talks about. And this means that now there are some practices who are using it as the main entrance into the general practice, and others that are using it as one of the key routes. But there's lots of evidence that the people who use these services tend to be they're more educated. In areas of high deprivation or sort of lots of ethnic minority groups, there is less use of this type of service. So by having that as one of the main routes of access to the practice, you're automatically starting to exclude people. There are practices who have used it alongside other things, still maintaining other routes, which seems to be probably more of the way forward for this. But then we get the other problem that we saw a lot in the GP sus study, which is these layers of access. It's almost like a lasagna, and nobody quite knows where they should go. Should I go on the phone? Should I go online? Which one's going to get me where? Should I do both? So there's a lot of confusion caused by that, I think, because it's something that practices have become quite reliant on to help them to manage the demand. I'm not sure there is any one kind of clear answer to that. Certainly, better thinking about what we found in the GP sus study, good kind of relationships and communications with the patients about what is available are crucial. And that's something that I've seen in some of my other research studies, that there's an assumption made that patients understand what is on offer and how it works, and that's not always necessarily the case. So thinking about how we better communicate that and let patients know about these layers and why they're getting pushed from pillar to post.
I think that came out really clearly in your presentation, this disparity of not only a sense of what kind of access is being offered, and that's picked up by a question from Richard, this kind of gulf between what patients think they're getting and what the healthcare providers think they're getting. And then similarly, the gulf between, the opinions around self-care, for example, patients feeling that, they need reassurance or advice on something quickly, and healthcare providers, believing that maybe those patients could stay at home a little bit longer. How do we start addressing some of those things so that, in the words of Richard, in the Q&A, these things are not left for receptionists to deal with, very thorny kind of contested issues. And any of the rest of the panel can join in. I'm speaking to Helen here, but obviously I'm sure the rest of you will also have some opinions on that.
I'll just briefly say, firstly, about receptionists, again, something that's coming through in our study, but other studies I've been involved with and others that I know some people here have done, is just the extra work that receptionists are now expected to do and the things that they are managing, which has increased greatly over time. I think that makes a big difference. Self-care is a tricky one, isn't it? Because I mean, maybe this is something that's right for some new research, but I think there's clearly a massive gulf between what professionals think that patients should be doing and what patients understand by self-care. So I'm going to let someone else come in now and say something about that.
Yes, can I say something a little bit about that? So when I first started in general practice a very long time ago, and we did talk a lot about educating patients, and then that went out of fashion. And Jake highlighted it, I think, in his presentation, that we had some very consumerist focused policies, which were, I mean, I even think I've got a quote somewhere of Gordon Brown saying that we should be more like Amazon or somebody. We should be more like, we should just get, basically get on with it. And if patients want access, then they should have it. And I think that's really interesting, because I have a real thing in my head about e-consults, which I don't think we've done the research yet, because I think it would be incredibly difficult. I don't quite know how we do it, but I do have a gut feeling that we may be getting some supply-induced demand. That if it's very easy to bang off an e-consult that asks for some advice about something that you might have asked your mother-in-law or the woman next door or somebody else about, that banging off an e-consult that's then got to be sorted through by somebody and responded to. So I have a bit of a thing about, and I don't know how you do research on supply-induced demand, but I suspect that the lower and it's very difficult, isn't it? Because if you look at the candidacy framework, because of course we want to lower the threshold for access for some people, but we probably want to push it up a bit for other people. And it's how do we get it right for everybody? And I think that's really, really hard.
Jake, just drawing you in there on that point, did you see in your review of the policy any reasons for some of them being abandoned? So that kind of, the commuter area, general practices, the ability to choose two practices at one time. Did you see any reflection there on supply-induced demand being a problem or a reason why things were changed or kind of abandoned?
Yeah, it's a fantastic question, Carol. So what I suppose we didn't do with that review was look at, I guess, the evaluative impact of these, where they went. That was slightly out of scope. But you do get, I suppose, looking down the policy documents through time, you do get a sense of the story about what things were quietly shelved, what things were sort of, shuffled off stage, what things took centre stage. And some of it is changing political priorities. Some of it is just changes in technology. I mean, I remember, and you can probably guess why this was shelved, CFAX being mentioned in some of the early 2000s. I think that's probably shelved for a good reason. But in terms of, I guess, why things kind of come and go a little bit, it isn't just fashion, I think. And it goes to this point, I think somebody has perhaps raised in the chat around sort of zombie policies. And I guess this difference between policies that were kind of abandoned because they weren't a good idea, policies that kind of keep coming back even though they are a bad idea, and something around perhaps policies that ought to be given a second shot almost. I think one point I would want to raise is, there are clearly some bad ideas that do keep kind of coming back like a bad smell, but there are some good ideas that we haven't quite got the implementation right for that still remain good, but you haven't laid the groundwork for them. You haven't sort of cultivated, commissioners at a certain level to allow them to thrive, to be able to sort of, really manage that kind of local complexity and tailoring. So that's almost where I'd want to take that question, Carol. It's a question of kind of resourcing and implementation rather than, what policies are good or bad. Some might be bad at a national level, some might be good at local level. It's immensely complicated.
Great, and I think in that you've addressed some of Charlotte's question as well on whether some of the approaches are generating unwarranted demand. But just to link it in, Jake, to you with another question from Fiona McKenzie, who's asked, and again, I'm not sure if this was in the scope of your policy review, and maybe the others on the panel might be able to speak to this question as well, but was behaviour change management factored into any of these initiatives? Again, going back to the self-care issue that Helen and Kath also introduced, we talk about self-care, but actually has there been any kind of behavioural science research behind how that's done and how effective it has or hasn't been, and how we might do it differently? So Jake, has there been any consideration of that at the policy level? And then Kath, Helen, you might be able to speak to whether there's anything on that in other regards.
Yeah, I mean, it's interesting at policy level, isn't it? It's quite sort of hard to tease out, I guess, that idea. I will say from kind of observations, and this goes back to what others were saying, kind of the more recent ones, looking at skill mix change, I think, I'm not sure whether I call it kind of patient education or whether I kind of call it patient behavior, but to go back to something I mentioned in the presentation about unintended consequences, I guess, there's something there for me around, well, we recognize that there is a challenge getting the number of full-time equivalent, permanent GPs up. We have skill mix coming in as, well, a solution to several challenges. One, widening the number of services available to patients in general practice, offering something different. But also, I dare say one of the objectives of that policy is, of course, to help general practice with the capacity challenges it's facing. So a lack of GPs, it's not task substitution, it's nothing so crude as that, but kind of improving the capacity of general practice to deal with patient need in their area. Having said that, on the face of it, improving the number of appointments you have, bringing those staff in, providing that additional capacity is useful to improve access. Just the sheer volume of appointments is a useful thing. It's not the only thing that goes in towards access, but it is a useful thing. But the challenges for patients navigating that, the challenges, patients knowing who best to go to in the practice, how practices themselves operationalize the skill mix change, convey trust from the GP to the patient and say, look, I trust this other member of my team, you can see them for X, how triage happens in the practice, all of these things, kind of the operationalizing of skill mix, is challenging, I dare say. So I think there's something for me around for policies like that one, for practices to do some of the work to help patients make the most of that and do the internal work. But there's also kind of that patient education element there. I don't want to call it education, that's not the right word, but enabling patients to know what's now on offer in general practice and connect with the right member of staff to see to their needs. I think that is very much kind of in the realms of an access challenge.
Yeah, thank you. I was going to ask Helen and Kath there to talk on the self-care. I might come back to you on that because I just want to move straight over to Azim, because Azim, you mentioned skill mix earlier and more appointments by non-GPs. So I'd like you to expand on that a little bit, because we've had two different questions coming into the chat on skill mix and specifically physician associates. With a question from Farhan on how far do you think the increased skill mix in the workforce in general practice has helped alleviate the access problem? And it seems that patients and communities still value the direct GP relationship and the trust that they have with GPs. And Amina asked a very similar question relating to the role of physician associates. So yes, more appointments. The measures of patient satisfaction are not really reflecting that as a good thing. So Azim, what are your
Thank you, Carol. Yeah, it's a very good question. So I think probably there's a role within primary care for skill mix. You do need a wide range of team with pharmacists, PAs, nurses, healthcare assistants, receptionists. But at the same time, also you need to have some care which is continuous as well. So care that where people see the same professional rather than having this very fragmented care that people sometimes receive. I think Kath mentioned behavioural change, and that is very important. Because people can be can be encouraged to behave in certain ways. But that's much better done if you're seeing the same professional each time. If you're seeing a GP one time, then a PA, then a pharmacist. It's very hard to get that message across to patients about how to approach their care, including self-care, prevention, their long-term conditions. So yes, I think skill mix is important, at least be implemented in a way that supports care that is not fragmented, and also people are working at the right level of their ability. So people aren't working above their experience or their training, which is a concern I think that some patients have. Remember, they're seeing professionals that perhaps are working at too high a level and perhaps above the level at which they're trained.
That's really interesting. Taking that continuity point further, have you any reflections for us, Azim, on how we might actually operationalize continuity in this kind of changed landscape? We've spoken about the triage and the e-consultations and the skill mix. How can we deliver the same type of continuity to our patients moving forward, and how might we measure that? And this is with respect to access and continuity often being pitted against each other. So how can we kind of bring them closer together and deliver continuity in this kind of transformed general practice context?
The first step is to get a grip on demand. So as long as there's a gap between capacity and demand, people will get care that's fragmented. They'll take the first one that comes up, whether it's because they'll be desperate for an appointment. So rather than waiting 2 or 3 weeks to see their known professional, they'll see someone the next day if that's available. So I think the first step is just to kind of address that gap. So ensure there is capacity for people to have some choice in who they see, and not being forced to see the first professional as an offer just because that's all they can get, for the next few weeks. So I'd say that's probably the most important step. We can also use records as well. So people like Helen have built a look on records, which can also be used to kind of support care across professional groups. But in my view, the most important step is just ensuring there's enough capacity so people have some choice who they see and not being forced to see the first professional who is offered to them.
Thank you very much on that, Kath. Yes.
Yeah. So it's interesting, isn't it? I think we've done some research on skill mix change, and I think it's one of the policies that as Jake highlighted with a lot of policies, there's lots and lots of unintended consequences that come with it. And I think the additional work for practices around working out and the mismatch. So we looked at the sort of categorization of patients often by receptionists, and then the matching of that patient to an appropriate provider. And of course you get it wrong sometimes, and so we're actually making care much less efficient very often in those circumstances. And I can say this because I'm towards the end of my career now, but I can say, I do think actually having someone having the person with the most qualified person seeing most of the patients is actually the most efficient way to work, because actually they can do everything and they don't need to hand anybody off, and they don't need to get them to come back, and they don't need to do they just do it, and they usually do it quite quickly. So I just think we forget that actually that the higher the level of skills, highly skilled practice nurses are the same. They're really skilled. They can deal with loads of things and deal with them very quickly. So I think I get why we've had to do skill mix, but I think we're going to look back on it in 10-15 years and think a lot of that was a bit of a sort of cul-de-sac, and actually we should be pulling back and thinking about. And I think the idea that there's GPs unemployed while we're please let's Yeah, let's deal with that.
So there are a couple of other questions in the chat, but I'm afraid we're completely out of time and we don't have time to do. I feel this conversation could go on for much, much longer, but we don't have the time. So thank you to all the panel and the speakers and the audience for being so engaged in what was happening and sending in such fantastic questions.